Yeah, also a space where there's very limited data to sort of say what the outcomes are of these patients. But we took a group of 80 patients who had received a covalent Bruton tyrosine kinase inhibitor and were either intolerant to that BTKi or had experienced progressive disease. And then we made sure that they had received Venetoclax for at least 2 months. And then we looked at their outcomes, and we looked at some subgroup analyses such as deletion 17p status, TP53 mutation status. We looked at whether them progressing on a covalent BTKi versus having intolerance would change their outcomes. And then we also looked at differences between fixed duration therapy with an anti-CD20 monoclonal antibody versus getting indefinite therapy would make a difference. And what we ultimately found was that our overall PFS was 29 months, so relatively similar to some existing studies. There's actually another phase 2 trial out there with Jones and colleagues that shows a pretty good PFS after ibrutinib. But it also showed that the patients with deletion 17p had a statistically significantly worse PFS than the patients without, as you might expect, right? And then it also showed that patients who had progressed on a covalent BTKi seemed to do worse than those who were intolerant, and those who received combination therapy seemed to do better than those who had received not combination therapy or Venetoclax monotherapy. And then one other interesting thing that we did find in that study is that with a median follow-up of 28 months, about 33% of the patients who received Venetoclax did not experience disease progression after stopping it. But within that group, the patients who had progressed on a covalent BTKi actually seemed to do worse than the patients who had just had intolerance. So it makes us wonder if those patients, the patients who have had disease progression, really are the patients who should be getting fixed duration therapy, or if we need to sort of change things up and do something else for them.